All right, we're just gonna go ahead and get started. Because our first speaker, who I will introduce shortly, is on the East Coast. So just to, of course, we couldn't plan for a tornado, but we just want to be respectful of her time. So just to start things out, welcome to the Spring Nebraska Neurological Society meeting. For those of you who I didn't manage to meet, I'm Dr. Laura Danielson. I'm the new president of the NNS. And obviously, we're just really excited to keep going with all the things that the NNS has already accomplished in the last couple of years. If you haven't had a chance, check out our updated website. Obviously, it's something that we keep updated on an ongoing basis, but it recently had a pretty large revamp. So check that out if you haven't had a chance to look. Before we start with our speaker, I'd like to extend a welcome to Grant Niver, who's here from the American Academy of Neurology. He actually directs the AAN state legislative agenda, which is something that they're focusing on more, and acts as a liaison to both the state societies and then also patient advocacy groups. So the best part of tonight is our two speakers, and we're going to start out with Dr. Minin, who's, like I said, on the East Coast by Zoom. So Dr. Minin received her medical degree from Thomas Jefferson University in Philadelphia. She completed her intern year at St. Luke's Roosevelt Hospital in New York City and her residency at Columbia Presbyterian Medical Center, also in New York City. She's completed 2 fellowships, the first one in neuropsychiatry and behavioral neurology at Massachusetts General Hospital in Boston, and the second in headache at Brigham and Women's Faulkner Hospital, which is also in Boston. Since then, she has been a faculty at the New York University Langone, not sure if I pronounced that hospital name correctly, where she's an associate professor and now chief of the headache division. So Dr. Minin has received numerous research awards throughout her career, including most recently the AAN Neurosciences Rewarding Award, which she's actually received 3 times. She has published more than 60 articles and has multiple past and current NIH grants. She's also been a speaker at both the national and international meetings on a variety of topics. So please join me in welcoming Dr. Minin.
Okay, thank you. Can everyone hear me okay?
Yes, we can.
Okay, great. Okay. Well, thank you so much for the opportunity to speak to you today. Your topic is, access to care, which is a real passion of mine. So I appreciate the opportunity to speak about this, especially in the context of one of my big areas of research, which is digital health, in particular mobile health. And so that's what we're going to be talking about today. So can digital health help improve access to care in neurology? This was meant to be somewhat informal. I'm sorry I can't be there for the panel at the end, but I'm happy to be emailed any questions and so forth if you have related to my talk. So as mentioned, I do have current funding and disclosures. I have NIH R01 funding from NCCIH to conduct app-based research, and I've contributed to developing intellectual property that is co-owned by NYU and IRD. And if the research is successful, NYU and IRD may benefit from the outcome, and so I am speaking briefly about some of that research. So there are 3 objectives today. The first is to briefly discuss, because I'm sure you're already a bit aware of telehealth because of COVID and so forth, but to discuss how telehealth and telediagnostic tools can expand access to care. The second is to discuss how mobile health, mHealth, including apps and wearables, can be used to potentially improve neurologic care. And the third is to discuss how neurologists might evaluate these digital tools for caring for their patients. So just briefly about telehealth and telemedicine. So the implication of telehealth and telemedicine, as I think a lot of us have realized even since COVID and so forth, that it can increase access to care, but even studies before that showed that. And so patients can make appointments with physicians and specialists who are not locally available. So it can target desert areas in terms of geography and geographic barriers, eliminates both travel time and waiting rooms. So if people are working, they can more easily get in the appointments. If they're dealing with child care, disability related issues, that can be really helpful for them. Can increase efficiency and productivity via teleconsultation in certain contexts. And there's also the potential for delivery of virtual therapies, whether they're psychotherapy, meditation, things like that, but even also physical therapy for certain neurologic conditions, and even biofeedback has been done virtually now. So And, there was a lot of question initially as to whether patients would accept teleneurology in terms of access to neurologic conditions. And there are tons and tons of studies. I could, speak for hours just on this alone. So I'm just including this one recent study that was just published, and it was a prospective study in particular of veterans, 277, which measured patient acceptability. And they did find that mean patient acceptability was fine. There's a positive association between comorbidity and acceptability scores, and the difference in whether one had one type of neurologic condition versus another was not significant. In particular, as mentioned, I'm a headache specialist, and so in terms of teleneurology and headache, using teleneurology and teleconsultation for headache, which as you can imagine, is one of the top neurologic complaints, even for a general neurologist, right? Can increase has the potential to increase access to care for those reasons I mentioned earlier, addressing time and geographic constraints. And when even outcomes, clinically important outcomes were looked at, such as migraine-related disability, which is MIDAS, an in-office group versus telemedicine group, there wasn't really a significance between the two. So that was really good news in that one could have the same improvement in migraine-related disability, whether it was an in-office visit or telehealth visit. There was also a decrease in average time for clinical visits and an increase in healthcare efficiency. And as you can see, this was published in 2019 by Dr. Deborah Friedman, and this was one of the landmark studies in headache before COVID-19. And my group published telehealth as a new care delivery model, the headache provider experience. And as you can see, there were a lot of positive attributes of teleheadache from the headache specialist perspective in terms of convenience. Didn't have to deal with parking and traffic for the patients, the stress of travel, which can be a big factor for patients with migraine and other disabling conditions, saving money on travel flexibility and so forth. So I invite you to look at this article if that's something you're interested in, but I want to move on for you. So digital diagnostics for headache diagnosis. I think this is really, really interesting, especially because there are so few headache specialists out there and because headache disorders are so common. I always tell the medical students that I'm teaching that one of the reasons that I went into headache medicine is because there are over 300 different types and causes. So the differential is actually one of the longest in medicine. And so you never really know who's going to walk in your office that day, right? But the challenge is there's so few headache specialists out there. And so what I think is interesting is there are two different groups that have published computer-based diagnostic algorithms and programs for patients to use that they can do on their own, basically administered questions on the computer to try to figure out what type of headache they have, and can even look at all primary headaches and some secondary headache disorders based off the International Classification of Headache Disorders criteria. So as I mentioned, it can be self-administered online. And I think there's a lot of potential to address underdiagnosis of migraine. And so there's a lot of good diagnostic accuracy of 92%, high sensitivity and specificity rates as well. And so they did do work to see that this computer-based diagnostic exam, can essentially mimic semi-structured interviews. So that's the reference there. There's another group as well at Penn that did the Penn online evaluation. So basically they were saying that also because for primary care providers, there are time constraints and so forth. And so they did this Penn online evaluation for patients to use before the visit and also had high sensitivity and specificity. So the reference is there. So I just think in a disease state where there's so few specialists, these have a lot of potential for helping patients even be advocates for their own conditions and to bring it to primary care providers, general neurologists, and so forth when they can't necessarily get to a headache specialist, or maybe even don't even need to get to a headache specialist. So moving on to mobile health, that passionate area of mine. So I think, how cool would it be if we could have apps to collect data for information we can't get from patients or caregivers, right? So if we're asking patients who maybe have cognitive issues and dementia, and so they can't actually provide information about their whereabouts and their physical activity levels and so forth. And it's hard to extract that information from family members or home health aides, et cetera. So maybe there are apps or wearables that could pick that up, for example. Also, I thought it was really interesting for those of you who were able to listen to the AAN, Dr. Sanjay Gupta at the AAN was talking about brain health and really preventive neurologic care rather than medicine for neurologic care, right? So I think that along those lines, apps can also help us to learn about the activity levels of our patients and think about brain health, preventive things to do, sleep hygiene, and other things. So I just wanted to bring it back to the recent AAN meeting. So not everybody is familiar with mobile health and the different terms. There are different terms from the NIH, from the World Health Organization and so forth, but broadly speaking, it's the practice of medicines and public health supported by mobile devices, whether they're cell phones, tablets, or wearables. And this is actually of really big interest, I would say, to the private sector. So as you can see here, that there was like $2.5 billion spent, and this is an old statistic, spent by just top funded digital health companies, spanning 12 areas of digital health. These were biosensor companies, including those that made wearables, that spent a ton of money, over $706 million, or 28% of their total funding. And interestingly, about half, 45% of companies considered patients to be the target end users, while 30% targeted providers, and a quarter had mixed end users, whether patients, providers, or employers. And if you look, a lot of these are really, new companies in terms of thinking about how long companies have been around. So the majority of them have been around for only about 20 years or so. But I really want to mention that the focus has really generally been on healthy people. So a lot of times we're treating patients with, really bad neurologic conditions, and these aren't the patients being studied. So if you look here, these are the studies by the top 20 funded privately held US-based digital health companies. And if you look here, it's really healthy individuals, followed by some ALS, MS, epilepsy. But when you think about high burden of disease and looking at clinical effectiveness, you see that there are very few red dots, right? This is not the area in which money has been spent for our patient population, at least 5 years ago. So I think it's also important to realize that the studies by the 20 top funded privately held use companies really didn't necessarily look at efficacy. And when they say that they've published data, you really want to ask what journals they've even published in. So just 28%, 29 of 104 studies targeted patients with a high burden condition or risk factor. Journals without any impact factors were the most common type of source of publications. These were small studies. Now, granted, it is hard to conduct larger studies for various reasons, but half of them were studies of less than 100 participants. And study purpose was clinical effectiveness in just 15% of studies. So I think this is really important because so many of our patients are using these apps out there and they haven't been studied. Or you may have heard from a colleague or thought, oh, this is a really cool app or wearable for my patients. But I think it's really important to think about whether there have been any real efficacy studies or effectiveness studies for these digital devices. So mobile health applications and wearables for neurologic conditions. And I do want to say that some of you are, maybe subspecialists and much more knowledgeable in some of these apps and wearables than I am, as I am a headache specialist. But I just want to kind of take a broad stroke overview from more of a general neurology perspective and really think about how it's really interesting how there are these potential opportunities for us. So just starting with types of data, for you to be aware, if you're not, there's active data, which is data where it prompts the individual to enter data. So maybe, for example, in our Relax Head application, they have to put in the number of headache days and the intensity and their sleep and so forth, versus passive data. So that's where the phone's collecting sensor data built in, maybe collecting accelerometer information, phone usage data, which may help in terms of if somebody is, more social, it can help with knowing if they're awake or asleep, etc. You can look at text activity, screen activity. And then there's also a term called digital phenotyping. which is moment-by-moment quantification of individual level human phenotype in situ using data from personal digital devices. So I think that's kind of interesting as well, where there have been programs developed where individuals are phenotyped based on their digital data. And so some programs also even allow for remote monitoring. So the ability to monitor patients' health remotely, whether patients are having specific symptoms, the frequency, severity, medication use, medication side effects, and behavior. And, you know, remote monitoring can have significant benefits. So if you can set up your office in such a way that even a medical assistant collects the data, so it doesn't necessarily have to burden the provider, right, like the physician, it can be really helpful. So it can increase time efficiency during in-person visit. It can help facilitate diagnosis, minimize recall bias, so you're not asking them to complete questionnaires the day of how many headache days or seizures, et cetera, that they had since the last visit, and could potentially also improve healthcare utilization, urgent care versus emergency department, because if you're picking up some trends or whatever over time, you may be able to call the patient in sooner or make a medication adjustment. So in terms of context, your patients oftentimes are using wearables, mobile health things. So in 2019, for example, when things were first starting out pre-COVID, almost a third of US adults reported using wearables, about half reported using them for daily use. So even beforehand, before the pandemic, people were using these. So what's on the market? So there's lots of wearables and devices that give this ecologic momentary assessment data out there. So I'm just going to call it a speed dating kind of for wearables for neuropsychiatric conditions, just to give you a little bit of a sense as to what's been out there. And so my question is, you know, for you to think about, is there an app or a wearable for your patient out there, right? There may not be data or there might be, but just a little bit of a flavor and how these things might be useful. So in terms of the Apple Watch, right, for stroke physicians and so forth, can maybe detect AFib, a flutter, and also, if you're worried about that, there's also ways you can check insulin, right? Blood sugar control through Dexcom and so forth. If you wanted to check about exercise, a lot of people ask about Fitbit. So how well do Fitbit studies stack up against, you know, more research-grade activity monitors? So in 2018, there was a systematic review which showed mixed Fitbit devices may provide similar measures for time in bed and time sleeping as professional grade equipment. But they're prone to markedly overestimate time spent in higher intensity activities and underestimate the distance during faster paced ambulation. Interestingly, they're unreliable in people with gait abnormalities. So I think that's important because a lot of our neurologic patients have gait abnormalities. And I think what's really interesting, I've been on some panels at the AEN, is that it's really difficult to study these consumer grade products because the algorithms change a lot and without warning. And so, as you know, probably in terms of doing research studies, you need the same intervention. But if they keep upgrading the Fitbit or the Apple product or whatever, it's really hard to study it because they may be adding new features and changing the algorithms, and those algorithms aren't necessarily privy to the researcher. So this is an example of something by my colleague, which I think is super exciting. It's Dr. John Torres at Beth Israel Deaconess in Boston. He developed MindLamp. And it's actually, there's a free database, just so you know, of all kinds of different apps out there for all different kinds of conditions, ratings of them, and so forth. So there's a free database if you wanted to go look at it. But basically, his work has looked at physical activity, symptom surveys, cognitive testing, timestamps, and geolocation. And so what I think is, you know, he has this Tetris, it's called Jules Trail, but, you know, he basically converted some of the regular tests like the Trail A to this smartphone game. And so I think it's interesting because he can basically develop some of these phenotypes. There's also Embrace. So for those who are looking for seizures, right? So there are smartwatches that can detect unusual or involuntary motor activity that can be associated with tonic-clonic or convulsive seizures. And it can look at some of the activity and send an alert to the wearer, as well as friends or family members who are wearing a companion watch. There's Brain Sentinel, which is another device to detect signs of tonic-clonic seizures. And so concepts to consider with some of these detection devices, there can be this automatic detection, which can be pretty effective and can also help caregivers' concerns regarding SUDEP to an extent. However, real-life seizure-like activities such as hand clapping and teeth brushing can also mistake for GTCs. So you need to be careful, and there's a lot of challenges with false alarms just in terms of scares from caregivers and so forth, just they're worried something's with their loved one and it turns out there isn't. So I think there are pros and cons, but certainly things to look into. There's also things for those interested in movement disorders like Parkinson's disease. There's a lot of concern, people with Parkinson's may have a more sedentary lifestyle than those without. And we know that exercise is good for those with Parkinson's disease. So there can be measures of physical activity to be worn for weeks at a time to try to see what someone's activity level is like to then potentially increase it. There are different ways in which wearables can be put on a patient. So can be to the lower back, can be to other areas to really measure this level of activity. And there was the Empower, which was a research study to understand the progression of Parkinson's disease, looking at dexterity, tremors, mobility, balance, gait, and so forth. So I think this is just interesting how it can measure tremor activity, for example, or give instructions for gait and balance. So what about if you're a headache provider like me, or a generalist who sees a lot of headache, right? Which may be a lot of you. So a lot of the work I have done is using this Relax Ahead application. So at this time, it's only available for those in research studies, although if you are in private or academic practice and are interested in bringing it to your institution or practice, there's the potential if you contact IRD, I suppose, but that's, this is not like a commercial for it or anything like that. I'm just trying to say that it's research and not commercially available. But basically the idea is that the app has a headache diary and has progressive muscle relaxation therapy. So in our studies, half of the people sometimes get just the headache diary and the other half also get progressive muscle relaxation therapy. So we're able to see whether progressive muscle relaxation therapy, which is grade A evidence-based treatment for migraine, can help improve clinically important outcomes like migraine quality of life, migraine-related disability, headache days, and so forth. So can we really take this evidence-based treatment, which we know can work, and put it into a smartphone application to make it scalable and accessible for patients? So that's really the goal of my work, and I had done pilot work in primary care. I just completed a K23 award of doing it in the emergency department, and I just presented our findings at the AAN meeting. And now my R01 is doing a phase 3 trial of the app in the primary care setting across NYU Langone. So it would have been equivalent to like a multi-site study, but I was able to say that we have an urban, so NYU Manhattan, we have a suburban NYU Long Island, we also have family health centers and so forth. So we're really able to get a very diverse patient population to recruit for our patients, so for our participants. So this is an area of interest of mine, as I said, in that can we create some scalable, accessible forms of behavioral therapy for the patients? And so this was the reason that I conducted this other study. It was a biofeedback study of a commercially available product in which I have no financial connection whatsoever. It's called HeartMath Inner Balance Sensor. And what it is it's a device that you put on your earlobe, and it transmits your heart rate to this app, and it then coaches you basically on how to change your breathing to then change your heart rate. And so we know that biofeedback also has grade A evidence for migraine prevention. Heart rate variability wasn't studied as much because it was a newer form, and it's really hard to find it for our patients, to find providers who are trained in it. Also in New York City in particular, a lot of those people don't take insurance. It's very expensive for patients. And so again, there's a lot of access issues. So that's why I did this study to see if this commercially available device that's just over $100, it's under $200, available online, can be helpful for patients. And so we conducted this randomized controlled trial to see if it improved quality of life for migraine. And we found that our results were not significant, but then when we looked to see of those who adhered to the instructions, they actually had pretty significant improvements in their quality of life. So of those who adhered did have improvements. And so I think that it's, good news in the sense of, trying to improve access for patients in a scalable, accessible way. So there are others also who have thought about biofeedback therapy for migraine using mobile health technology and wearables. So there's Juva for migraine. And so this is examples of that, where there's a video camera that looks at heart rate variability, blood volume, pulse, and respiratory rate. And they had also wanted to do finger temperature, galvanic skin response, and oxygen saturation. And then there's also this team in Norway that created Cerebri that captures physiologic data from wireless sensors, and they instruct patients to relax and breathe for 10 to 15 minutes per session. And they've published stuff in pediatrics. Also, they've done studies in adults. And so there's a few different products around that hopefully can help headache patients in a scalable, accessible way. So the question is, right, and here I'm talking about these 3 different products, right? But how many, apps are there out there really for these different kinds of conditions? So we did a study at NYU that we called the mHealth App Study here. And so we investigated intervention and tracking for apps based in the Google Play and Apple App Store. So basically what we did was we took the top 5 most disabling neuropsychiatric conditions. That was stroke, migraine, depression, Alzheimer's, dementia, and anxiety. And we took the top apps for them. So in both, as I said, the Google Play and Apple App Stores based on reviews. And so we basically reviewed 83 apps. And interestingly, but not 18% of apps did not use evidence-based interventions. And none of the apps meeting study criteria, really worked that great. But, in terms of having wearable technology, they were more apps and so forth, but not really wearables, to be clear. So at any rate, this is the reference for it. But the point being that when you look at these top apps on the market out there, there really isn't much research being done on those apps specifically, which I think is important, again, if you're thinking about recommending them to your patients. So what is the evidence? So the groundwork, this is from the American Psychiatric Association for mobile health. They were looking at ground. So what's the context and background? What's the risk for assessing for harm, the evidence, usability, and adherence, and interoperability? So what's that evidence? So then I mentioned the app study where we looked at the top apps based on reviews. We decided, why don't we do a study on clinicaltrials.gov, in which a lot of people register their trials, because most journals these days will only accept pre-registered trials. And so we wanted to conduct a study of clinicaltrials.gov to see, are, there being studies of these high burden neuropsychiatric conditions in terms of apps or wearables. And we wanted to see, are there temporal trends in registration of the studies? So like, is there an increase essentially of the number of studies being done over time, given the interest in both doctors and patients and using apps and wearables? We wanted to look at design features and other study characteristics, frequency and timing of any outcome change, and whether the studies were actually even completed based on whether they reported results on clinicaltrials.gov or in journal publications. And so this was a breakdown in terms of the characteristics of neuropsychiatric mHealth trials on clinicaltrials.gov. So you can see here, I'm a headache specialist, right? And the green there for migraine is 3%. So first of all, there were only 137 studies, so not many, right? And migraine is the second most disabling condition worldwide in terms of disability adjusted life years. And yet only 3% of the studies we're looking at for migraine. So this is a breakdown just kind of based on, in case you're stroke or epilepsy and so forth or general. But I think it's just really telling that there are all these products out there again, and not much is being studied on them. So our conclusions were that despite the increasing use of health-based smartphone applications by the general public, the snapshot on clinicaltrials.gov suggests few such applications for high-burden neuropsychiatric conditions are being clinically evaluated in trials. And furthermore, really unfortunately, the results reported by the authors are available for under 10% of such of the trials. So it was only 7%. So that was, you know, I don't want to say unsurprising, but pretty unfortunate, because it would be good to be able to have results to share with our patients. So just some other examples here of how this can be in clinical practice. So Dr. John Porras, who I mentioned before, is using, was looking at current smartphone apps for targeting suicide. Most of the ones in the commercial market are not evidence-based, but there are thoughts in terms of, can there be signs of potential suicide based on app use? So anyway, so there's lots of wearable technology. There's the potential for real-time monitoring, but lots of unanswered questions. And so one of my areas of interest here is adherence. So say we know something can be effective, like that heart map inner balance sensor I mentioned before, that was the biofeedback for migraine, right? How do we get patients to adhere? That's one of the biggest issues. Just like you can prescribe a medication and patients may not pick it up from the pharmacy, you can send patients also for behavioral therapy and they may not attend those appointments. People download an app and most people do not open the app the next day. So this is really challenging in terms of mobile health adherence. And we know that people with chronic illness may be less adherent to apps. So there's a study of diet apps where the controls were 76% adherent, but those with chronic illness were only 16% adherent. All right, so here I'm talking about increasing access using digital health. Well, I think that we really need to look at methods and novel methods to improve adherence for our patients with neurologic conditions. There's also a question of informed decision-making around apps for adherence, right? So I think when we're prescribing a medication, we're pretty careful about describing risks and benefits and things like that. But I'm not sure we're explaining it as much within digital health. And there's a lot of unanswered questions that I think do need to be discussed with the patient. So for example, who is collecting the data? Who owns the data? Where the data might be shared, right? So these are all important questions in my mind, which oftentimes is pretty difficult to even figure out. We may not be able to figure out, and we're pretty, highly educated individuals. We may be able to see an app and look at the privacy policy and not understand it. So then how would we expect our patient to understand it? So I think that's really key. I think that there's high interest in mental health apps in particular. We have a lot of patients with comorbid depression and anxiety, but it doesn't always translate into high adherence and so forth. So for example, there was a study of 113 patients at a private insurance clinic and 73 at a state department mental health clinic. Those in the private insurance clinic were more likely to download a mental health app compared to the state one, but actual rates of reported current app use were comparable at each clinic, only 10%. So that's what I'm talking about, adherence. I think there also is a lot of questions about coaching and how to really get patients to engage and have that follow through. People also had concerns about privacy and also different areas of motivation for trying to use the app. So those at the state clinic viewed cost savings as the greatest benefit, while those at the private clinic reported time. So I think also in terms of potential motivational interviewing, which is a behavioral technique to get patients to try to see why they could find it beneficial in terms of their own words and thoughts and feelings in order to increase usage. I think this is important information. It's really, why does an individual think it might be helpful? So I've touched a little upon this. This is toward the end, but regulations, privacy, and security. So the FDA has tried to get involved, but it's really hard. There's so many products out there, so it's pretty challenging. So be concerned about how apps share health data, experts say. So different universities have said different things. And as I said, there's a lot of questions about ownership Likelihood that the data from an unregulated health app can be shown to a physician is also almost non-existent. A lot of the apps out there don't have like clear reports that can be shared with providers and so forth. So if you are recommending an app, how are you going to get that data is a question. I touched upon informed consent in the digital age. It is pretty different than informed consent for other things that we do. Because as I mentioned, so there's personally identifiable, depersonalized, and anonymous. So what's being done with the data that's inputted? I touched upon the issues with privacy policies, not being able to understand them. And then I think this is very interesting. How might the data be used? Well, employers oftentimes are giving out devices or apps as part of wellness programs, but then they might get the data, right? So I think there could be potential concerns here because say you're monitoring fatigue, but the person or your patient is in a high-risk job. So say they're a pilot or a surgeon. What would happen if the employers know that you're fatigued or that you have trouble sleeping? So I just think there are a lot of big questions and concerns here, right? Obviously, there are a lot of advantages too. So it would be great to better understand fatigue in our patients with concussion, in our patients with multiple sclerosis and migraine. So I think there are a lot of concerns, but also a lot of advantages. And then to just kind of end on with AI, there's a lot going on with AI right now. There's certain things that can be much more time efficient potentially. It can be used for appointment scheduling. Natural language processing can be interesting in terms of trying to help with underdiagnosis of health conditions. There's a lot of great potential things for it, but there are also limitations. So it does not account for any behavioral signs or social determinants of health, can impact diagnosis, treatment options. Accuracy is based on available data. So what's really interesting is there's this non-medical example of wolves and huskies, and there was pretty good accuracy in terms of figuring out the wolves and the huskies. But then when they removed the background of snow, the computer algorithm didn't work because it turned out it was really looking at whether there was snow in the background. So just something to think about. There was another medical example where there was pretty high accuracy for diagnostic testing of a CT scanner in ICU patients at a particular hospital in New York, and it was published. It was very good findings, but then they tried doing this algorithm elsewhere in another set of ICU patients, and it wasn't reproducible. And it turned out it was because it was a different kind of scanner that was being used, and it was looking at other things related to the scanner and not so much what the diagnosis was and so forth. So at any rate, there are a lot of issues because it's really the data that you put in. How good that data is also can affect the data that you put out. And again, there are also privacy and security concerns with AI. So in conclusion, I think that there's a lot of integration of telehealth, mobile health, and potential for remote monitoring. I think there can be a lot of increase in access to healthcare for both providers and for various other services as well. I think it can help target time constraints for patients and for the physician. I'm really excited about some of these diagnostic standardized questionnaires in terms of helping patients be their own advocate and helping hopefully get diagnoses sooner for something like migraine, which is so common and really undertreated. With over 47 million Americans having migraine, I think that this kind of thing is really useful. I think that there's also potential here for addressing healthcare utilization concerns with remote monitoring, as I mentioned, and increasing access to data. So again, I think that this remote monitoring can really give us more data about our patients that we might otherwise be able to obtain and also minimize recall bias. I think the future is bright and that there's a lot of data out there and a lot of potentials for apps and wearables being developed. But on the other hand, there are lots of apps and wearables out there. And so it's important to figure out the right one, right? There's little data and evidence behind them. So that's important to try to seek out. And then again, there are questions about collecting lots of data points, but who's going to own them, who will have access to them, privacy considerations, and then also a lot of limited data is actually getting to the physician. So how do we bridge those connections and the patients want those connections? So thank you to my funders. Thank you to my wonderful mentors and collaborators over the years. And I'm happy to give you my email address because of the time issue, but it's Mia, MIA.Minen, MINEN at NYU Langone, LANGONE.org. And I guess the conference organizers could probably also provide it if necessary if you didn't capture that. So thank you. And I hope everybody's okay and their families and loved ones are okay.
So Dr. Minen, hopefully you could hear the clapping in the background. There was plenty of it. Before I open to the rest of the room for any questions that they may have, I do have a comment and question myself. As someone in neuromuscular, I haven't seen a lot of the wearable usage yet, except for I do have a young woman who's in her 20s with myasthenia gravis, and she got very into the myasthenia online forums and actually made her own app to track myasthenia gravis activities of daily living after she started a new medication, Vyvgart. So she was like, after the first infusion, this was my score, and the second infusion, this was my score. And so my question for you is, have you already noticed that there's a generational difference between the ability or how much people use the apps in the real world?
Yeah, I do think so. I also think there's also a big difference in terms of what the patients or our participants are looking for and their expectations on use. I think that our average age is oftentimes like 38 to 40 or so in our studies. And I think that the younger patients or participants really are expecting like top of the line technology and multi-million-dollar apps and so forth, a very different kind of grade of app or wearable than what we have on a research basis. So that's one of my biggest, things that I've noticed versus the older patients are less about all the gadgets and gizmos or, the appearance of the app, and are a little bit more like, okay, this is, to help my health and so forth. So that's been my main thing that I've noticed in terms of age difference so far.
Right, is there any questions in the room? Yes.
Is there an estimate or average percentage of people that could never, ever participate in telehealth? Due to language problems, intellectual problems, financial problems, because I know it would vary in different populations, but do you know anything about what is the estimate of people that will never have access to something like this?
Dr. Minen, I don't know if you heard that, but just to state it again, do you have any estimate of the number of people who, for a variety of reasons, whether that's location or internet access, would never be able to utilize telehealth?
Yeah, it's an excellent question. I kind of wonder if our next speaker might be able to answer some of that, but I don't know that statistic per se. I do know that colleagues of mine, for example, like at Wake Forest, have told me about patients that, live far, who really couldn't do as much telehealth, and then other from, because they came from neighboring states and didn't have the technological ability from some of their patient populations. But I think the vast majority have been able to use it. I know that a lot of patients who do have the intellectual disability that you've talked about. It's oftentimes, a caregiver or somebody else from the facility trying to help facilitate. It can be difficult if it's just one-on-one. I also think that, obviously there can be the language barriers that you brought up. But I don't have the statistic of never being able to use it like you said. But the interesting part is that most people do have access to a smartphone. So even if they don't have a home, for example, even if they're homeless, they still likely are likely to have a smartphone.
And I think that where a lot of the telehealth legislature that was happening, the more rural states, there was a lot of push of, well, we have to have internet access then, and internet access was still an issue in large swaths of the country, especially in rural areas. Any other questions? Yeah.
That was a great talk. Thank you. And it gave a real nice survey of the field. with the focus on headaches. But I want to say that we have a lot of work ahead of us, and I think the idea that we don't have access, the other side of that is this ability to measure behavior in the field with personal devices kind of democratizes medicine. It's different in New York, where I'm going, than it is in Nebraska, where we go 500 miles west. But there are folks who just can't make it into the clinic, and it's really hard to schlep them 100 miles or 200 miles. So actually having the devices that you mentioned could be really important, as long as we know what we're really getting, which is another issue, right? We have vendors who sell these devices and we might not have access to the raw data, or we do. And then there's a question of how do we validate the data? How do we verify the data in terms of their technical integrity and their clinical relevance? So that's another important thing ahead of us with all of these devices. And then another question that maybe you.
Can I just respond to that one while I remember it? Is that okay? Just to say, I totally agree with you, and that's why I think that, you know, we're not at the end of the, you know, spectrum. We're still very much at the beginning, and I can relate in the sense I have patients from all over, even New York, you know, upstate and so forth, who are maybe not as designated as you, but definitely hours and hours from neurologists, and so that's why they're telehelping into me in New York City. So I think it's across the country that we do have some of these deserts, but you're right in terms of the internet access, and I'm not trying to say that we're you know, at this great state right now, because I think there's a lot to still be learned. But yes, I want to hear your second question too. I just didn't want to.
Certainly New York is rural, especially away from New York City. I mean, there's like lots of farms and there's Woodstock. So the other issue is you have all these data and you have to figure out how you actually get access to them. And you are a researcher who knows what she is doing. Well, to link the data to the hospital requires all these layers of IT, which is like the sort of new parking. It's like everybody used to get mad at where they had their parking space. Now they're mad at IT and IT security. You know, you have to get the data inside of the firewall that protects the institution, generally the hospital, from heaven knows what's on some of these devices. Anyway, that's the tack that the institutions take. So that's another issue. And then there's the enormous opportunity, not just to drill into a patient, but to aggregate the data. So, you know, you have at your hands a new way of doing clinical trials, and to aggregate the data in ponds and pools and oceans, whatever you want to call them. So that raises another issue, but it also in terms of federated and centralized models. But there's the issue of how do I get to them? And then what you raised was the exciting opportunity with AI, new programs with machine learning to actually make sense out of all of these data, and to make sense out of the real world, to get data that's clinical trial-like from places that you never would have got otherwise, like rural and remote rural areas that are not near a big university like NYU or Harvard or Hopkins. So it's a huge opportunity for everybody. I also wanted to raise you were going to say something.
I was just going to say, I completely agree. And it's very hard in terms of, you know, developing one of these kinds of products and then having institutional, you know, buy-in and trying to get, as you said, you know, the Epic support team or whatever of a big institution. And, you know, sometimes it's actually even easier if it's a private group, but then they use the Epic. So people are using different systems, different versions. So I completely agree with you. That's a whole other, could be a whole other talk for an hour. And then also to your point, I've also spoken to exactly what you're saying. You know, when we do research studies, we have patients sign, you know, informed consent and data share agreements, but those data share agreements are not really necessarily about, patients aren't thinking this is data sharing, you know, from an AI perspective of, you know, across the country or even internationally, multinational. So I do think we need to rethink this whole informed consent process and data sharing so that patients really do realize that. So if, you know, as you said, there's a lot of great potential, but we're not there yet in terms of educating the patients about how that data could potentially be shared later on.
Thank you. One other point is, I think you raised the question of how effective medicines are in the real world. And when you think about it, it's not just the patient who's sometimes dilapidated and can't take their own medicines. It's the caregiver. So with the techniques that you mentioned, it's possible to look at these sort of dyadic and social interactions that mean so much to the health of our patients. And there are ways of looking at that with, tools in the home, tools in the workplace, and that's a really important opportunity for us. And
You're
then-
right, there are digital pill boxes, there are even in psychiatry, there are even like little what do you call it, like digital things that they put into the pill to see compliance, like with some of the medications. There's a medication for schizophrenia. I think that it tracks to see that you actually took it. So it's kind of crazy the opportunities or the potential for tracking out there that, as I said, but you're right.
So a couple last things. One is, there are opportunities for chatbots to actually do this stuff in an automated way and to feed that information to you, who then gets in touch with the patients, which I think is kind of exciting. And then you mentioned issues like experience sampling, ecological momentary assessment, to look at things like depression. But now you can actually have robots, like social robots, that recognize what's going on with the patient's speech, their countenance, make inferences, and then actually intervene and say, "What's up, Bob? What's wrong?" And maybe contact the neighbor or a psychiatrist or a general practitioner. So great talk at an exciting time.
Thank you. Totally agree. I mean, we're actually piloting AI for reply to patient messages at NYU right now. I'm part of this pilot. It's pretty interesting seeing how, it can generate the draft if you want, and you can either say yes, no, and you give a thumbs up or thumbs down if you don't think it's on target. And obviously you edit it and go through it and all, but it's interesting. It's a sign of potential future help with workflow and all different kinds of things out there. Well, thank you. Great points.
Any other questions? Yep, one more question.
Being the conduit between the hospital, ER, and neurology, the expectation when a patient is discharged from the ER is follow up with neuro or primary care in 3 to 7 days typically. We all have 3 to 7 months for neuro for the complicated patient, and if you're lucky, if you do have an established primary care, it's typically at least a month to get in. So trying to keep the burden of a migraine patient or a headache unspecified out of the ERs and better controlled outside of the ER. What are some ways that we can help kind of bridge that gap and have better control?
Yeah, so if you have the patient already, and this isn't really digital health so much, but some places have integrated into digital stuff in terms of Epic forms and things, but we developed a migraine action plan some years ago that was we got the idea from an asthma action plan that they use in pediatrics, where basically your doctor has a form, and it could even just be a paper form of what medication should be used if there was an asthma attack for a kid. So similarly, if the patient has a migraine, what they could be given potentially in an urgent care setting and so forth, to even avoid the emergency department. So I'm a big proponent of trying to improve care in urgent care, actually. I've done some research and published some work on that because I think that, patients with headache disorders, they really don't like going to the emergency department for obvious reasons. It's not cost effective. They also get unnecessary tests. So if we can actually educate urgent care providers a bit more and have those medications, even like IV metoclopramide on the formularies, I think that can be a big win for patients where if they, have a bad attack, it's after hours, they can't reach the doctor, they go to urgent care and not necessarily to the emergency department. So I hope that that's more of an area for future to improve access.
Yep, another question.
I have one question. When I was still in clinical practice at Mayo, we talked a lot about some of this wearable technology and this data, and one of the things that has always been a concern is, you know, clinician burnout, fatigue is real, and now you're adding potentially billions of more data points that are coming in, and how do you stratify the data? And how do you collect it and disseminate it, and how do you interpret it as a clinician in a way that isn't just overwhelming, because you could be getting so much data now from all these sources. And how do you do that in a way that's still time efficient, because you're still on a schedule and have other patients to see, and not overwhelm yourself.
Yeah, I think that's a really important question. That's why we went and interviewed 20 headache providers to see, to do qualitative work, to see if we were to do remote monitoring, how could it be, you know, what are the pros and cons, how, you know, burnout's such a huge issue. And so I think we found that it really varies by practice, you know, whether you're in academia versus private and different, there were so many different factors, but to answer your question, I think that's why I mentioned before, you know, having medical assistants try to collect some of that data, because there can be reports, you know, and graphs and things like that. And actually, you can bill. So that's an important part. You can bill for a lot of this remote monitoring. So if you add in APPs, for example, you can bill for this. And so to try to help with the burnout, I think the burnout's a huge issue, as you say. And so I think that's why it's important to bring other people onto the team. Obviously, easier said than done. You need institutional support, et cetera. I fully get that. But I think that would be like the big picture goal if you can make it happen.
So more about collating the data at a set point rather than not receiving notifications on a daily basis from every one of your patients with a wearable.
Right. So like, you know, if your wait is, you know, going to be 9 months to see a neurologist because of access issues, you know, after starting a medication, you know, or I don't know, it's not a great example because you should be following them. But, you know, for example, say I see a patient at 3 months after starting a medication. If you saw that there was something, you know, if you had someone monitoring at 6 weeks, right, instead of at the 3 months, you might be able to act and intervene sooner than waiting for the 3-month appointment, if that makes sense.
All right, Dr. Minnan, thank you very much for zooming in with us, and hopefully it's
Thank you
not
for
too
the
late for you.
invitation. You know, thank you. And thank you for the great questions and discussion. It was really meaningful. So I think it was great. Thank you.
Good evening. Can everyone hear me okay?
Yep.
Wow, I've had an incredible day. I know many of you have as well. I was not expecting this. It's my first time in Nebraska. Thank you very much for inviting me here. I may come back. I'm not sure. I'm a little traumatized. But thank you, Laura. She picked me up from the airport, dropped me off, and then literally like drove almost into the tornado and came back and is like, you know, running this show. So I want to talk to you about a model we have in Boston, but I'm going to personalize this a little bit. I have no disclosures. The objective is to describe the implementation, early experiences, and future directions of a neurology clinic that's embedded within a community health center in Boston, and to describe how this could be a strategy to improve access to outpatient general neurology and tertiary headache care, which is my subspecialty. So I'm going to preface this talk by this quote by Mark Twain. There's no such thing as a new idea. It is impossible. We simply take a lot of old ideas and put them into sort of a mental kaleidoscope. The reason I use this quote is because my prior chair, Marty Samuels, I don't know if any of you knew him, he passed away last year. He really drilled this concept into us as his trainees. You know, you think you're on the verge of something brilliant. It's been said before. You know. And so I want to share with you, as I was reflecting on this talk, a few experiences in my life that I think led me to do this. And so here's a picture of Leonidion, Greece. It is a small town in Peloponnese in southern Greece. It's where my family comes from. And my great uncle was a primary care doctor there. He was on call 24 hours a day, 365. I mean, 24 hours a day, 365. 365 days a year. In the summers when I used to visit him as a kid, he'd say, let's get, get it back in the Jeep. I'm going to show you around. And there'd be syringes in the back of seat. We'd go visit patients. He's like, I just have to go visit this patient real quick. It was just part of his life. And I think that's, the old school physician that's existed, around the world. And that was my first experience of a physician. And then my family moved to the United States when I was 2 years old to Hershey, Pennsylvania. I think there were some Hershey chocolates out there. My father is a psychiatrist, and this is our church at the top right. I'm Greek Orthodox. It's our community. And what happened was after church, there was coffee hour, and it was not uncommon for the parishioners to come up to my dad and start reporting a lot of their medical symptoms to him. I mean, and they weren't just psychiatric. And then he took on a lot of them as patients after hours, and they were very grateful for that. They would always come and find us, and there'd be like these trays of like delicious like spanakopita and and then later on they'd call the house, and then when they found out I was in medical school, they'd start asking me about their antidepressants. It just like it's so access to me was, there wasn't a clear divide between personal and professional life, and that's sort of what I grew up with. And here's a picture of my dad. He many years ago went back to do volunteer service in Greece, and here he is with some tents, and that was after an earthquake in Crete, where people were living in tents, and he and his wife, who's a psychologist, were providing care. And this van is actually a van that they use, and they go to rural villages twice a week to provide psychiatric care to community health centers. So a lot of what I'm going to talk about or I witnessed and even in my own family. So a little bit about me. So, I come from Harvard, right, in Boston, and I don't know if that conjures any feelings or not, but I grew up, in central Pennsylvania. Bottom left here, we have Amish County, and that's where I went to medical school. And interesting experiences there. I remember as a medical student, I was asked to take the history of a child who had DKA, and I was told he's encephalopathic. You're not going to get anything from him. And his dad was there. And then as I was taking the history, I realized he wasn't encephalopathic. He just didn't speak English. He spoke Pennsylvania Dutch. And nobody had realized that, so this was a population that had a unique agreement with the hospital because they're not insured. And the community elders would decide when you got your medical care. So we sometimes saw very delayed presentations. That child hadn't been to a pediatrician, I think, for 3 or 4 years, and he was around 7 years old. I did my internship at Beth Israel Medical Center in Lower Manhattan. It was a kosher hospital. I didn't know what that meant until I went there, and I learned very quickly. It was very multiple different backgrounds. So there's a huge Chinese population. There's an Asian services floor. It had the largest methadone maintenance program in the country. And all of those experiences were eye-opening to me. And I saw how, health systems really have to accommodate to the populations that exist in their local communities. To the right is Jacobi Hospital. It's a city hospital in the Bronx. And when I went to interview there, for my internship, I was surprised that the signs were in English, Spanish, and Albanian. Albanian's a very small country. And it turns out the largest Albanian speaking population is in that area. And so all the signs are in that as well. And there's a whole program to support Albanian speakers. And then after I did my training in the Bronx and at Montefiore, I went to Brigham and Women's and the Harvard headache program. And I was invited to stay as faculty. And I said, I really want to do general neurology. This is in my heart. And so I want to, have a general neurology clinic here at Brigham. And I started that. And I started to see a lot of referrals not from Boston, not from the neighborhoods. They were from across the country, from Maine, even international patients, second, third, fourth opinions. And I said, this isn't really what I signed up to do with my life. I really wanted to treat the people who live like right around the hospital here, and I need to figure out a way to do it, and I need to figure out why they're not ending up in this fancy clinic that's just a few blocks away. So I was having these experiences and in this clinic for several years, and then it was 2020, and the whole country was kind of processing George Floyd's death and the Black Lives Matter movement, and medical institutions were examining institutional racism. This quote is by a neurology resident who I worked with, who had published this in JAMA Neurology on chokeholds, and it was titled, why neurologists need to make their voices heard. And I think, George Floyd's brutal death really, as a neurologist, was also hard to witness because of the mechanism and how we understood what carotid compression does. And so this was, the environment, and now we're living in a very different environment. But at the time, medical organizations, the AAN, condemned systemic racism. My own organization committed to addressing local inequities. They put up a lot of money and grants for research, and I saw this all going on, and I said, but what are the inequities in outpatient neurology access? And I talked to my mentor, Elizabeth Loader, and she said, well, I don't think anyone's looked at that. I was like, well, let me just check PubMed. Turns out someone had, and that was Altaf Sadi, who's a colleague of mine at Mass General. And this is based on outpatient visits. And so if you are of low income across the US, regardless of your race or ethnicity, or regardless of your income, if you're Black, Hispanic, or Native American, you're 30 to 40% less likely to have an outpatient neurology visit. And then newer studies have shown that in addition to that, you have less access to a neurologist in areas that are rural. I don't think that's a surprise. Men are less likely to have access to a neurologist, those who are uninsured, and individuals with disabilities, hearing, vision, and ambulatory. We recently had a headache fellow interviewee, and he wanted to study headache in people who communicate with American Sign Language. And I thought to myself, I've had 1 or 2 patients in the last 7 years in my headache clinic, and he told us that the percentage of people in the US who communicate with ASL is about 4%. So, there's some barrier here. Why am I not seeing these people in my clinic? And so if you can't access the diagnosis and the clinician, you're going to have a worse outcome. It's just the logical conclusion. So again, this has been studied across subspecialties. So you have worse neurologic outcomes for Black Americans, including higher mortality in stroke, epilepsy, Parkinson's disease, underdiagnosis, and worse disability. Headache, which is my subspecialty, is what I've focused on. The research shows that if you're low income, you identify as Hispanic, Latino, or Black, you're less likely to receive a headache-specific diagnosis. So what does that mean? So when you present with a chief complaint of headache, which is not a diagnosis, instead of being diagnosed with migraine, you're more likely to be diagnosed with headache not otherwise specified, or those other possibilities. So if you don't get a migraine diagnosis, you're not going to get a triptan or a CGRP inhibitor. The likelihood is significantly lower. And there's been research that shows that actually the rates of chronic migraine in the US are highest in Hispanic women as well as Native Americans. And so as headache physicians, we hope one of the things we can do is sort of intervene with our preventive medications, especially when patients are kind of at the earlier signs of higher frequency episodic migraine, to prevent them from going to chronic migraine or to revert them back to episodic migraine. But if you don't even have a migraine diagnosis, how are you going to get those medications? So where do people get their headache care? Headache is very common, and it actually depends on which country you're in, which region you're in. This first study was from the UK, and headache accounted for 10% of all primary care visits. In the US, it's the 7th most common chief complaint in primary care clinics. However, gaps in PCP headache education may limit use of preventives. This was a study by Mia Minnan, who just talked to us actually. And, there's several reasons for this. PCPs right now, there's a crisis in this country. They're dealing with the patients who have multiple comorbidities, shorter visits. They have increasing complexities of presentation. And there's individual comfort with ruling out secondary headache disorders with knowledge of new medications. So I want to focus now on Boston. So, I'd seen some of this data and I said, well, how does this apply to the patients in my neighborhood? And this is from a study that was done by Brigham and Women's back in 2019. And they had looked at some of these factors and they showed that actually in our city, if you were Black, you had a higher mortality rate if you were diagnosed with a stroke compared to the Boston average. I couldn't find anything specific for headache, however. And then they broke it down to different areas of the city. So this map to the right, which shows COVID rates, and I'm sure that these have been created for, perhaps in Nebraska, many other cities in the Northeast at least. And they sort of reflect a lot of the inequities that we see for many diseases. So, the more purple is higher rates of COVID, and then the kind of fainter lavender is lower rates. And so these darker areas, Dorchester, Mattapan, Hyde Park, these are areas that historically have been poorer, that have had a higher percentage of patients who are Black and Hispanic. And these are the areas that also have higher rates of diabetes, hypertension, and obesity when you control for all other factors. There's some other interesting observations this report had published. So intentional injuries, intentional injury-related emergency department visits were also higher in these areas. And when you think about this, what are the potential neurologic consequences? Cardiovascular factors increase the risk of stroke. Of course, intentional injury can cause blunt traumatic head injury, headache, chronic pain, post-traumatic epilepsy, spinal cord injury, and on and on and on. So going back even further, we have older maps. This is a map from 1938. It's like most commonly referred to as redlining, right? What does that mean? So that was when areas during the Federal Housing Administration Act in 1934, certain areas were deemed sort of less appealing to live in and less, and the real estate value was actually lower. And those areas more commonly had people who were Black and not white. And we've seen that division based on these historical maps continued. It affected the creation of highways. It affected the creation of high-speed internet, grocery store locations, and on and on and on. And I'm not going to keep stressing this point, but we see this in a lot of U.S. cities, and we see that in my U.S. city. So what our hospital did was they tried to go out and talk to people, which is always a good idea, and through community focus groups and say, what do you find to be the most significant barriers to accessing care at the Brigham, and what do you think we could change? And the most significant barriers included language, immigration status, navigation, care challenges, transportation, lack of culturally sensitive approaches to care, and being underinsured. As a reminder, Massachusetts was the first state in the country to require all of its citizens to have health insurance. So we have very high rates of insured patients, but some are, less well insured than others. And the residents suggested that the hospital actually needs to make them feel welcome. They recommended that the primary care needs to expand, and that they needed to embed health services in their priority neighborhoods, which were those neighborhoods that I pointed out before. And so, for many years, the hospital had relied on 2 community health centers. These are hospital licensed community health centers to really help serve these priority neighborhoods. And these two are named Southern Jamaica Plain Health Center and Brookside. They're located only about a mile apart, actually, and they treat, at least this is actually just for one of them, about 20,000 patients per year. All right. And the mission really is to serve communities with disproportionate burden of poverty, housing instability, and other social determinants of health. The community health centers are designed to address the population-specific needs. So Southern Jamaica Plain Health Center and Brookside actually are located in an area that was traditionally populated by a high percentage of patients from the Dominican Republic. So there's a lot of Spanish-speaking patients there. So almost all staff at the Southern Jamaica Plain Health Center Clinic speak both Spanish and English. They're bilingual, although they might not be certified as such. And there are also community resource specialists on site, and so on. I'm going to go into this in a little bit. Now, community health centers have a long history and they exist all across the United States. They exist in Nebraska. You might be aware of some. I Googled it this morning just to make sure. They started in 1965. The first one was actually founded in Dorchester. H. Jack Geiger and County Gibson were the founders of this movement. And then subsequently, they were actually funded by President Johnson's War on Poverty. And this really spurred the movement. And there are 4 requirements to be a community health center. You have to be located in an area of high need. You have to provide a comprehensive set of services, open to everyone, and there's a patient majority governing board. So there are patients who meet regularly in addition with the administration for decision-making actions. Today, community health centers are the medical home for 31 million people. And they've been found to be cost effective, estimating generating $24 billion in savings annually. So back in 2020, my question was, this all sounds really great, but what's the role of a neurologist, you know? And so I actually reached out to the directors there and scheduled a meeting. And I said, you know, seems like this is a population that faces barriers in accessing neurologic care. How do you feel about having a neurologist on site? Like, what's your sense? What do you see? And they ran some numbers and they told me, you know, every month we put in about 30 referrals, and this was at one of the sites, 30 referrals to neurology. And our impression was that very few of those actually get completed. And the main referral locations were within 3 miles down the road, Maine Brigham and Faulkner Hospital. And we see a lot of headache. You know, they're very excited that headache was my subspecialty. And so it was a very nice meeting. And we decided I would do in-house neurology consults and I see patients for any neurologic reason and at one site. And these would be referred by their primary care doctors, patients who are 18 years and older. And also patients who were referred from the other sister community health center, Brookside. The nice thing about this community health center is that because it's hospital licensed, it actually has access to and it's completely integrated into the medical system. And so I can order MRI imaging that's ordered at the main, you know, conducted at the Maine Brigham or, you know, any advanced kind of diagnostics. There is an in-house lab and equipment. And so we estimated that I needed about 2 sessions a week. And I said, you know, I'm going to do the same thing that I do up the road at the Graham Headache Center, and I'll bring my, you know, we'll figure out what needles we need. We'll figure out how to get the Botox. We'll do the nerve blocks, and we're just going to do them here. And then I had to bring it back to my chair and make sure he wanted to support that. So I had a presentation there, and, you know, in the context of that time, they were very supportive. And in fact, they really wanted to have our residents involved. And I thought that was a great idea with the premise that I didn't want this to be sort of a drop-in site. I wanted this to be sort of a commitment, people who wanted a continuity clinic there. And the first year we had 2 neurology residents. Every year since then, we've had 3 neurology residents. And, you know, one of the kind of requirements was that I would get an equitable salary and benefits without an increase in clinical load for doing this, which might sound idealistic. So essentially what happened, because you need to know the business of things, is that the Department of Medicine bought out 2 of my sessions per week. So I had the same salary, but they just paid the Department of Neurology. And so for me, it was pretty straightforward. You know, I kept the same contract with Department of Neurology, same benefits, all that, but 2 of my sessions were covered. So we started the clinic, created a mission. And this is what the clinic looks like. So this is the fun kind of like Friday night slideshow part. And that is on a nice bright day. This is a recent picture with a solar eclipse, which I thought was really funny. This is our administrative director here on the left, Pavel. This is Dr. Roselli. She's one of the internists. Dr. Levy back here is a psychiatrist on staff. Angeli, who's here in the pink, she's one of the lead nurses. She actually was a patient here as a child. And then had both of her daughters who were patients here. One of them had a very rare disorder, and she decided to change course in her professional life and went to nursing school and then has become a nurse here. So, and we see that a lot. I mean, it really has a community feel there. The one medical assistant I work with a lot, you know, he sometimes actually like can help me with a diagnosis, you know, because he'll say, you know, oh, this guy's walking really different than how he was, you know, at church a few days ago. And I was like, well, tell me how he's walking at church. And that level of insight is so important to me because I'll have a clinical sense. But when you see a patient for a half hour and it's your first time meeting them, you know, sometimes you need that collateral, and to have someone there who has that level of medical observation has been really helpful. So I'll give you a tour here. This is the first floor. It's a pediatric waiting room. There's also a laboratory there. And there are also specialists there who support patients for housing, finances, insurance. These are the steps going to the second floor. This was like a photo op for cardiovascular health. It was Wear Red Day. This is the second floor, adult medicine. This is what the clinic room looks like inside. So I have rudimentary Spanish speaking skills. Like if you force me to do a stroke code, I can do it. But to do a complex visit, I can't. So we have these iPad interpreters, and that's what I use most of the time. You know, the patients get roomed. Most of the staff are bilingual, as I mentioned. But then I conduct the visit with this. And I'd say 90% of the time it works well, and 10% of the time it's very annoying. And then we have a behavioral health team on site. I showed you Dr. Levy. We have several licensed clinical social workers, a psychologist. And the nice thing is that, you know, when, especially in headache, I think, but for a lot of neurological conditions, when you identify the need that you need, you know, co-management with a psychiatrist or therapist, you know, you're just sending this referral to like who knows where. And so to have somebody in the office and then have access to their notes and get their feedback and communication has been really helpful, especially in patients with like post-concussive disorder. As I mentioned, there are community resource specialists on site. There's actually an EPIC order called Social Determinants of Health. So if an MA or anyone along the visit identifies there's a lack of adequate food, housing, unemployment, you know, you type this in, you pick what you want, and then one of these community resource specialists meets with the patient. Sometimes if it's urgent, they can actually meet with them in clinic. I had a patient over the winter who was going to be undomiciled that night. Like they were living night to night with a couch on couches, and she had a child who was under 18. So I just had the community resource specialist come in and see if they could find her a shelter room that night. The clinic also has a health promotion center. It's like a completely separate building, 2 doors down. And they have a very active daily programming. They really like Zumba there, Tai Chi for seniors. And then there's actually food distribution 3 times a week. So not only if you identify food insecurity, you can actually like, this is Evelyn, and we give her cell phone number to patients, and she can connect them with these programs. And then we have a racial justice and health equity team, and we meet together once a month. And they've actually published quite a bit. This is from the New England Journal of Medicine Catalyst. And what, our team does is that if we find, different people work on different projects, or if we identify there's some issue in our clinic and our interactions, we bring it up. We don't let it kind of fester under the surface. We've kind of created this agreement on how we're going to bring things up and discuss these in sort of a safe space. All right, so here's kind of like the limited data portion. So in the first year, we had 400 patient visits, 465 in the second year, 45% were new patients consults, 33% were virtual, 42% video. And I think, this is lower than what we were seeing on the main campus. And the reason for that was poor internet access for some of these patients. Prior to the clinic's establishment, so then we started getting interested in the numbers, right? We didn't do this before we established it, but we actually ran the numbers and we saw that less than 30% of the PCP requested neurology consults had been completed. And then we looked at our completion rate and it was very high. It was over 90%. And why is that? This is a patient's medical home. They've already been there. The primary care doctor who they know and trust is encouraging them and knows me, right? So there's already a sense of trust there and familiarity with the staff. And they, if there's a language issue, I mean, the staff has already been, the access issues have already been addressed. Like I didn't come to address the access, they were already addressed. I just brought what I already do. And so, now we're looking at sort of 3 years of data. And so what are our patient demographics? 68% identify as Hispanic, 41% prefer to communicate in Spanish. About close to 60% are insured by public payers. And what do we see in terms of diagnoses? Well, headache is like by far the most common. And I don't know if part of it is because I'm a headache specialist and they know that. I expect it to be the most common, but I think, part of it has to do with me as well. Neuromuscular disorders are common. A lot of these can be things like radiculopathies or neuropathies. Cognitive disorders are common, but as I was looking at the data, I think what's happening is that we have a lot of follow-up visits. These are just the new patient visits as well. But you see there's actually like a real spattering. And one thing that's been very exciting for me, and I think for the residents too, is we see some very rare neurologic disorders as well. Spinocerebellar ataxia, stiff person syndrome, progressive supranuclear palsy. I mean, this is just like within the last few months. And I think, that has been really exciting and good opportunity to catch these patients and then, if needed, refer them on to subspecialty clinics. In terms of what is being prescribed, new medications are being prescribed in only a quarter of new patient visits, and the majority of those are headache-specific medications, and that really includes everything from NSAIDs to the CGRP monoclonal antibodies and gepants. And then we brought Botox treatments to this clinic as well. And how did we do that? Well, I just put in the Botox order and saw what happened, essentially. Sometimes we can talk, but I find that just doing things for the one patient who needs it and figuring out the system and kind of building the road that way can be effective. So this was Jose, my MA, and he was very excited when we got our first Botox approval because we kept trying after multiple attempts. And then, after we did that, then the nursing staff administration was like, well, what are you doing with this Botox? Where are you, so then they got interested and they connected us with the pharmacy head at Brigham. And then we got a courier to bring it, so things sort of fell into place. There were things I hadn't thought about, like the primary care doctors, were noticing that I was prescribing subcutaneous sumatriptan, and they said, how did you get this approved? I said, well, most insurance covers 2 injections a month, and they didn't know that. And so we had this back and forth with the primary care doctors. And then for some of the stable patients, who weren't going to be continuing to see me, they just take over the script, which is nice. It's sort of the shared care model. Nerve blocks, very easily are done with lidocaine, which is widely available. So that was easy to do. And then our residents. So Jillian, who I mentioned, Berkman, she's actually a stroke attending now at Vanderbilt. She was the first one who had the interest to come. And then it's kind of progressed. And so Dr. Nigam is our last one. And so this has been for me an opportunity for residents to get more outpatient neurology training. And I think they enjoy it because they're outside of the hospital. And we can focus on headache, which neurology residents really are interested in getting more exposure to, and not just chronic refractory migraine patients who get admitted to the neurology service, but really like routine outpatient care. And Dr. Nigam is going to be joining us as a headache fellow, and she's the first one from our neurology residency in like 13 years to join us. So really excited about that. So I laid out a few benefits here. So that we've perceived: improved access for those at greatest risk of refractory headache conditions. The care is provided in the medical home, improved communication with PCPs. I mean, the PCPs, it's really kind of like an open door policy that we have with each other. If my office is open or their office is open. The other day, actually, I had a patient who was a follow-up for epilepsy, but she was coughing and she was like, epilepsy is fine, but I'm coughing. I'm like, well, I don't know what to do about this cough. And I was trying to figure this out, and her albuterol inhaler wasn't prescribed. And I just walked out the door, and the primary care doctor just happened to walk by, and I just was like, she's like, I'll just add her onto my schedule. So that was great. We solved that day, and so, but sometimes it's not so easy, but with a simple epic message or, knocking on a door, you can really get a lot done. And then let's see here, some challenges. I think, this is kind of across the board. Whenever you're starting something new in a center that's not organized to do specialized treatments, the staff's unfamiliar with it. So whenever there's staff turnover and we try to do a prior authorization for one of the new CGRP drugs, there's always like a little bit of like, what are we doing here? Why are you prescribing propranolol? A primary care office isn't as familiar with the migraine preventives as a neurology office is. So there's an education, and that's a little bit more of a burden on the provider. And, it takes time and investment into developing the relationships with the primary care team. You don't just like send off a letter, but I really enjoy that. I mean, I find that I get to learn a lot more about the patient, and the primary care doctor's impressions of the patient, and they really value me as well. I mean, and that feels really good, feels very nice. So low no-show rates, that's a good thing in general, but it does result in busier clinics, especially if you double book your clinic. If you're at an offsite location, you have residents, needing to travel there, that can be a barrier. And then finding culturally sensitive Spanish language resources, which is getting better, but that has been a barrier for some disorders. So we came up with some solutions, like using established protocols for Botox. We really wanted to be consistent with what we were doing at the headache clinic, and improving our primary care doctor communication. When I first got there, I was just like more ambitious. I don't know. I have 2 kids now. I only had 1 then. And I used to write a newsletter once a month and say, what was the most interesting case of the month, and like include references and things like that. And they really liked that. And but I haven't done that for a couple of years. As I mentioned before, trainee interest in headache medicine. One thing my chair really wanted me to do is like, I want you to measure outcomes. And that is actually very hard to do in a real world setting like this. One thing that I thought of as well, if I have very refractory migraine patients and I can treat them in the outpatient side, perhaps we can prevent emergency department visits, but that really has to be expanded to a larger scale. So sometimes measuring the outcome, you have to become a little bit creative or need larger numbers. Another benefit is that you join sort of a new community of neurology colleagues. And what do I mean? So I'm going to give you an example. This is Dr. Michael Stitzer. He is a colleague of mine who works in Arizona. He works for the Indian Health Services. And through the American Headache Society, we met, and he treats a very different population. It's rural. The issues in his population include poor access to supermarkets, electricity, clean water, and, you know, talking with him, we face some of the same issues, but also some very different ones. And I just find it very inspiring when I meet people like him and hear about the work that he's doing across the country. And there are many colleagues like this, and we sort of, you know, get together in different groups at AHS and AAN, and that's a joy. And so I'm going to leave you a quote by Marty Samuels. If you ever met him, he was very funny. He was known to be very funny, and he was a great writer. And so we all talk about physician burnout. And he actually wrote an article called A 9-Step Program, an Antidote to Physician Burnout. And the first recommendation was try working in a truly resource-limited environment. And he said, what we would hope is to learn something about how it is that people often function so effectively in these challenging environments. This kind of work in truly resource-limited environments does not require traveling across the world. One can accomplish this in one's own city or town very easily. It's possible to practice medicine very effectively in a resource-limited environment. Learning this lesson helps one feel much less sorry for oneself when dealing with some of the creature comforts, the absence of which cause some of the frustrations that lead to the phenomenon of burnout. All right, so I think I'm gonna end there, and I know it's very late, or maybe not for people who don't have 1-year-olds, but but I'm happy to take any questions and comments.
So I do have a question. If you had to pick one thing for those of us working in private practice, or a lot of us are at the university hospitals, obviously we're not in the community health setting that you started this, but if you had to pick one thing that could improve access to care, what would it be?
I think it really depends on your population and who you are trying to provide access for. The definition of access varies depending who you talk to. I was the clinical director for general neurology for several years at the Brigham, and the Brigham has a very clear definition for access. It is the time to a new patient appointment from when the patient calls in to when they're seen. And that's all they care about. That is the metric. And they want the Department of Neurology to see a patient in 30 days or less. And that metric has not been hit like since they wanted that 4 or 5 years ago. In fact, it kind of keeps increasing and then kind of going down, but it's like 70, 80 days, like at its best, I would say. But it's who are you seeing, right? And I think we talked a little bit about this. If you're seeing second and third opinions, I mean, those are patients who've already had a consultation, you know. If your clinic is designed, for example, when I had interviewed in New York, some headache specialists, and these are academic centers, they only take cash for the first visit, right? The clinician doesn't ever see it. It's the institution, right? So it's like $500 for a new patient visit, $700, you know. So there are some structural kind of, I think, opportunities. So one thing we had thought of was, you know, if you've already been seen by a neurologist, we didn't implement this, you know, perhaps we create a second opinion clinic, and that clinic only functions once a month. So if it's going to take you, you know, 6 months or 12 months or whatever to be seen, so be it, you know. Or maybe there's someone who is actually interested. Actually, Marty was interested, and we could never come up with what that clinic would be called. People would call it the undifferentiated clinic, and he was like, this sounds like a terrible cancer, like, you know, I want to run that. But, you know, I think there's a place for that. Right now, my hospital system wants to really increase international patient visits again, because they think that's going to be, financially lucrative. But that's going to take the place of referrals from the local community, from rural areas of New England. And so I think, these discussions need to happen on an administrative level. So I don't think there's just one thing. I think there are a lot of different measures, who gets access and when. One thing we tried to do, which is partially successful in the general neurology clinic at Brigham, was to hire a nurse to triage the referrals and to like kind of do like an urgency sort of scheme. Like these need to be seen within a week, these need to be seen within a month, and these are like, who knows when. That's kind of another thing that can be helpful. And I know other people sometimes just kind of close their clinics and don't accept new patient appointments for a certain period of time. But that's can be very limiting as well. So I think, many hospital systems have clinics in different areas of the city or different areas. And, when I think of community neurology, I think of, you don't all need to be at the mothership, right? Like, you don't all need to be at the kind of the academic center where you see the most complex cases. I think doing outreach to the kind of community clinics can be a good opportunity. So I didn't answer your question, but I'm just kind of providing different suggestions. One kind of general philosophy is that when you think about the person who faces the most barriers, like the deaf patient, or if you can envision a patient you've seen who's just had the hardest time accessing care, if you try to design your clinic around that patient, that ends up making it easier for everyone, right? Like that's why we have handicap accessible clinics, because it doesn't only make it easier for people who are handicapped, but people who walk with canes and people pushing strollers and, all of this stuff. So there's just a few ideas. Yeah. Yes, yeah.
You have a big heart
Uh,
and you're very brave. And I think you probably have problems beyond what you even mentioned. I mean, it's bad enough to have to rely on an iPad to translate, but there's also the cultural literacy, healthcare literacy, which even if you translate word for word, doesn't necessarily get to who you want to communicate with. And then there's issues of distrust. And then there's issues of stigma, and some folks won't come forward because it's shameful to have a certain condition. I'm sure you deal with all of that, and probably you're solving problems along the way all the time.
Yeah, I mean, the word mareo, and it doesn't translate to English. I don't know if anyone's a Spanish speaker who has dealt with this, right? Oh, it's the broad term dizziness, but then if you push but dizziness is so hard to diagnose anyways. You push the patient, is it vertigo? Is it syncope? Is it anxiety? And it's mareo, like, your doctor, you're not getting it, it's mareo. And so I think, the longer you spend with the patient population, the more you understand. Your attitude is, we've seen this, right? Like if I walk in, I'm like, oh, Spanish speaking, let me get the interpreter. I think affects a lot. So I always introduce myself in Spanish. I say, I understand a little bit, not enough. We're going to use a Spanish interpreter. Most patients are fine with that. Some are disappointed, but I don't have that feeling, most of the time, honestly, I'm someone who follows my instinct, whether that's a good or bad thing. And most of the time when I leave that clinic, I feel good. I really do feel good. I feel like I've done good things. And, on occasion, something didn't go well with the interaction. I think about how I could have improved it and whatnot. But I think one thing that's helpful is honestly that we meet once a month. We've been doing this for years with the racial justice group, and it's people of all different races, backgrounds, identities, and we're very open about who we are. And if we feel that kind of discomfort or tension during a clinic visit, what that might mean and getting that insight. There's a data point on there, where And they've looked at this where patients in our healthcare system, like 45% identify who are Hispanic, like half of them identify as other. And it's like, well, the US federal government says you need to pick white or black. And when you talk to when I talked to Pavel, who's the director, who's Dominican, she's like, I don't identify as white or black, I identify as Hispanic. And I know that race and ethnicity are considered different. So, the way we communicate about these things coming from different backgrounds can be very different. So I think greater understanding of that, the more we interact with each other. It's a process. I mean, I don't have many answers. I'm learning. All right. Okay, thank you.
All right, well, thank you for everybody who made it to the end despite the tornadoes. And keep an eye out on the website for our fall meeting, which should actually have some details popping up there before the end of June. So keep an eye on the website and everybody make it safely home.
Thank you.